Well, thank you everyone, and thanks Mary. So today what I'm going to be doing is talking with you about the results of a randomized controlled trial and 9-month follow-up of an emotion regulation group treatment for self-harm. So as I'm sure everyone in this audience knows, self-harm is a very clinically relevant behavior among folks with BPD. So by definition, this behavior does not include suicide attempts, and yet there's a lot of evidence, and Charlie actually mentioned this earlier, that engaging in deliberate self-harm increases the risk for future suicidal behaviors as well as completed suicide. It's also the case that self-harm has been implicated in the high levels of healthcare utilization among folks with BPD. And yet, interestingly, despite how important this behavior is within this population, there are actually very few empirically supported treatments for self-harm specifically among folks with BPD. So we do have some short-term treatments for self-harm in general, but these actually have not been found to be terribly effective for folks with BPD, and in some cases there's actually evidence to suggest that these treatments are iatrogenic. It's also the case that although we do have 2 very efficacious treatments for self-harm within this population, these are difficult to implement in a lot of communities just due to their duration and intensity. And so what all of this suggests is that it may be important to come up with a clinically feasible intervention for self-harm specifically within this population. And thinking about things that are brief and less intensive, and perhaps treatments that could actually serve as an adjunct to ongoing treatments being provided by clinicians in the community. And so if you're trying to do a very targeted treatment, there's a lot of evidence to suggest that a very useful strategy is to target the theorized function or underlying mechanism of the behavior you're trying to target. And when it comes to self-harm, there is now a preponderance of literature, both theoretical and empirical, that suggests that emotion dysregulation is a central mechanism underlying self-harm. So emotion dysregulation has been found to be linked to self-harm among a variety of clinical populations as well as non-clinical populations. And it's also the case that self-harm now, for most people, has been found to serve either an emotion regulating or an emotionally avoidant function. And so what all of this together suggests is that there may be utility in targeting emotion dysregulation in order to treat self-harm, with the basic idea being that if emotion dysregulation is driving this behavior, if we can decrease emotion dysregulation, we may in fact in some ways decrease the need for this behavior. And so based on all of this, we developed an adjunctive group treatment for self-harm among women with BPD. And this is a acceptance-based behavioral therapy. It is a 14-week group, and we developed it specifically to augment the treatment provided by clinicians in the community and come in and directly target both self-harm and its underlying mechanism. And in terms of how we approached emotion dysregulation, we actually based this group on an acceptance-based definition of emotion dysregulation, where we have skills that target several different dimensions. And so there are skills for increasing the awareness, understanding, and acceptance of emotions, skills for teaching clients how to control their behaviors when they experience emotional distress, skills for flexibly modulating the duration of emotions rather than trying to avoid or control emotional arousal, and then also strategies for increasing willingness to experience distress as part of pursuing meaningful activities in life, as well as the willingness to move forward with these things despite distress that is there. And this treatment draws heavily from both DBT and another acceptance-based treatment, acceptance and commitment therapy. So the study that I'm going to be presenting today, prior to conducting that, there were actually 2 trials that provided support for the utility of this treatment for self-harm, BPD symptoms, and emotion dysregulation, as well as psychiatric symptoms in general. One of these was a very small RCT conducted right here in Boston, and then another was an open trial that we conducted in a far more underserved setting. And so the purpose of this study was really to extend the research in this area. We wanted to look at this treatment within a much more socioeconomically and ethnically diverse group of patients in a far more underserved setting where people have very little access to mental health treatment, and then to also look at a wider range of outcomes, and in particular focus on outcomes related to adaptive functioning and how people were actually living their lives. And so the study that I'll be presenting today looks at the efficacy of this treatment in an RCT, as well as the durability of treatment gains over a 9-month follow-up period. And so to this end, women who had BPD and were currently receiving outpatient treatment were randomly assigned to either receive this group in addition to their ongoing outpatient treatment or to simply continue with their outpatient treatment alone for 14 weeks. So they were our waitlist group. And what we hypothesized is that adding this treatment to their ongoing therapy would have positive effects on our outcomes of interest. So in terms of inclusion criteria, participants were required to be female, 18 to 60 years of age. They had to have a history of repeated self-harm with at least one episode in the past 6 months, although you'll see they had far more self-harm than that. They also had to have an individual clinician of some kind. And we wanted to make this group widely available in our community where actually lots of folks do not have individual therapists. And so the individual clinician could be a psychiatrist, a case manager, just somebody with whom they were meeting at least semi-regularly. And then they also had to have either a threshold or subthreshold diagnosis of BPD on the DIPD. In terms of exclusion criteria, we really tried to keep these to a minimum, again, to kind of increase the generalizability of our sample. And so we excluded only for primary psychosis, bipolar I, and past month substance dependence. So these are our demographics of our full intent to treat sample. So this is a sample of 61. And you can see here the main take-home message is we were able to get a relatively socioeconomically and ethnically diverse sample of patients. These are our clinical characteristics of this sample. And again, if you look at this, you can see these folks do seem pretty representative of other BPD outpatient samples. High rates of suicide attempt, relatively low overall functioning. They were struggling a fair amount. And then here's our diagnostic data, and again, as expected, high rates of co-occurring axis 1 and 2 disorders. So in terms of our outcome measures, participants reported at various times on their frequency of self-harm, as well as their frequency of other self-destructive behaviors that have also been proposed to serve an emotion-regulating function. So things like drug and alcohol use, risky sex, suicide attempts, disordered eating. They also completed 2 measures of emotion dysregulation or emotional avoidance. So the first is the difficulties in emotion regulation scale, which actually is based on the same definition of emotion dysregulation on which we based this group. So it targets all of the dimensions I noted earlier. And then they completed a measure of the tendency to avoid unwanted internal experiences, particularly emotions, because we think that's really relevant to emotion dysregulation as well. In terms of our psychiatric symptoms, we provided 4 measures. 2 had to deal with BPD symptoms. 1 was a clinician-administered measure. The other was a self-report measure. We also had the BDI to measure depression and a measure of separate scores for depression, anxiety, and stress symptoms. And in terms of our measures of adaptive functioning, we looked at interpersonal problems particularly relevant to BPD, social and vocational impairment, as well as overall quality of life. And what's important to note about our quality of life measure is that participants are specifically asked to rate their satisfaction with domains of life that matter to them. So we're only trying to get a sense of the extent to which the things that matter to them feel like they're moving in the right direction for them. And all of these measures were administered both pre- and post-treatment or waitlist, as well as 3 and 9 months post-treatment. So in terms of preliminary analyses, we had an overall treatment dropout rate of 24%, which is kind of in the general range of what we would expect with this population. At the baseline assessment, we did not have any significant between-group differences on any of the demographic, clinical, or diagnostic characteristics I showed you earlier, with the one exception that our waitlist group actually happened to be getting a little bit more treatment as usual, which turned out to be a really good thing, because then when we took into account the therapy time associated with the emotion regulation group, the groups actually ended up getting the exact same amount of therapeutic contact time across the study. So in terms of our analyses examining treatment effects, we used a latent growth model process for examining these, which basically allows us to model a linear growth pattern from pre to post treatment, as well as the effect of condition as influencing either the latent intercept or the latent slope. And because we were able to use multiple imputation, these analyses are for an intent to treat sample. So bottom line for the Rtc analyses, and I'm going to show you graphs of these in a moment, is that we did find significant treatment effects on self-harm and other self-destructive behaviors, emotion dysregulation, Bpd symptoms, depression and stress symptoms, and quality of life. So for the graphs that I'm going to be showing you, they're all set up the same way. The treatment condition is in green, the waitlist condition is in red, and for all of our measures except for quality of life, what we want to see is the lines going down. So that's going to indicate improvements. And so I'm going to start by showing you the figures for the measures where we actually found significant treatment effects of this treatment. So this is for self-harm. We then have self-destructive behaviors, emotion dysregulation, the Bpd symptoms on our clinician-administered measure of Bpd, depression symptoms, stress symptoms, and quality of life. And you can see here what's notable is that at pre-treatment, both of our groups actually started in the negative range on this measure, meaning very poor quality of life. But by the end of the treatment, you can see that the folks in the treatment condition actually did move into positive values on that measure. So the next two slides are for measures where we found effects that approached significance and were associated with a medium to large effect size. So something we'll definitely want to follow up with in future research. So this is the findings for the tendency to avoid unwanted emotions, as well as our Bpd relevant interpersonal difficulties. And finally, these are the slides that actually look at measures for which we did not find significant treatment effects. And you'll see here that for the most of the cases, the reason we failed to find treatment effects is that our waitlist group actually showed improvements on these measures as well over the course of this 14-week period. So you see here Bpd symptoms on the self-report measure, depression symptoms on the Beck, anxiety symptoms, and this is social and vocational impairment. And again, what you can see is we did see improvements on this measure across both of our groups, the treatment and the waitlist condition, who was just receiving treatment as usual. Now, in terms of looking at the maintenance of treatment gains during our follow-up period, what we did for this is look at all participants who received the emotion regulation group over the course of the study. So this included both those in the treatment condition and those in the waitlist condition who then received the group. So the sample was 51. We used a very similar analysis plan, but this time we used piecewise linear growth models, which basically allow us to model linear change during treatment and then again during the follow-up period. And one thing to note is that when we look at all participants who received the emotion regulation group together, that they did as a whole show significant improvements from pre to post treatment on all of our outcome measures of interest. But I think what's more important with these analyses is that we also saw that all of these gains were either maintained or further improved upon at the 9-month follow-up. And in particular, we found additional significant improvements from post-treatment to 9-month follow-up for some of our primary outcomes of interest, including self-harm, emotion dysregulation, the tendency to avoid unwanted internal experiences, Bpd symptoms, and quality of life. And with the other measures, we found stability during this time. So once again, I'm going to show you these figures, starting with the measures for which we found continued improvements during the follow-up period. So again, this is our measure of self-harm. And what I wanted to show you here is actually our observed means for self-harm. So these are when folks came back in and actually reported on the frequency of their self-harm, because I wanted you to get a sense of what the actual data look like. This is our measure of emotion dysregulation, where again, you can see significant improvements during the follow-up period compared to the treatment phase. The same for experiential avoidance, same for BPD symptoms on our self-report measure of BPD symptom severity. And again, the same for quality of life, where we see these further continued improvements during the follow-up period. And then I'll show you the figures for these measures where we saw stability during the follow-up period. So this is self-destructive behaviors, BPD symptoms on our clinician-administered measure, depression symptoms on the BDI, our other measure of depression symptoms, anxiety symptoms, stress symptoms, interpersonal problems, and social and vocational impairment. Now, the final thing that we wanted to do with this study is to actually look at the extent to which these improvements are actually clinically significant. So certainly it's one thing to show a change on a measure that may or may not actually reflect real change in the lives of these folks after they've completed treatment. So for these analyses, we used the set of folks who had completed the treatment. So it's a sample of 39. And in order to determine clinical significance of findings, what we're wanting to see is that people must both report a reliable improvement in their symptoms, but then also reach normative levels of functioning on the measures. Because in the end, I think that's the reason we do this research, is that so folks can actually have noticeable improvements in their lives. So this slide is a bit dense, but I'm going to walk you through it. So these are our clinical significance findings for some of our primary outcome measures. And the first thing to note is that at post-treatment, approximately 1/3 of our participants reported clinically significant improvements in self-harm, emotion dysregulation, and BPD symptoms. And one thing to note is that here, for normal, meaning normal functioning for self-harm, it was actually an abstinence of self-harm. In addition, you can see that these findings actually got stronger at the end of the follow-up period. So at this point, not only did about 50% of our participants report clinically significant improvements in self-harm, emotion dysregulation, and BPD symptoms, but we also saw rates of greater than 40% of folks reporting clinically significant improvements in depression symptoms and interpersonal problems. So what does this tell us? Certainly, I think these findings do provide further support for the efficacy of this treatment. In addition, this was the first study to actually look at the extent to which these findings would be maintained during a follow-up period, and I think we found really strong evidence to suggest that they are. And again, even more importantly, that we did see continued improvements on some of our primary outcomes during this follow-up period, particularly self-harm, emotion dysregulation, BPD symptoms, and quality of life. And so I certainly believe that this provides further support that it may be useful to consider this as an adjunctive treatment to the therapy being provided in the community. A couple of things to note. This treatment does not require being matched with a particular type of individual therapy. So most of the clinicians of the participants in our study were providing either supportive or psychodynamic treatment, which is not at all consistent with our model, and yet we still found these results. In addition, although this was neither planned nor were we aware until the end of the study, it actually turned out this group was the primary treatment for 43% of our participants, who ended up not seeing their individual clinicians very much when they were in our group. But certainly that seems like a positive result. So in terms of thinking about the future, so to date, the only research we have is looking at women with BPD. So certainly it's not clear to what extent these findings are going to be generalizable to adolescents or men or folks without BPD. It is the case that right now there are 2 to 3 trials that are about to get underway looking at this with adolescents and young adults without BPD. So at some point I think we'll have some more data on this. To date, we've only relied on either self-report or interview-based assessments, so certainly, particularly with regard to emotion dysregulation, I think that being able to include more objective measures of emotion dysregulation pre and post-treatment would be useful. We also do need to continue to examine emotion regulation as the mechanism of change in this treatment. So to date, we have looked at data from the first 2 trials I mentioned, and we did find that in those 2 trials, we did find that emotion regulation was the mechanism of change. that changes in emotion dysregulation mediated the improvements in self-harm we saw over the course of the treatment, and yet I definitely think that this needs to be replicated in this larger sample. I also think that it's important to look at other mechanisms of change in this treatment. So certainly, given the fact that this treatment was developed specifically to target emotion dysregulation, it seems like the best candidate. And yet it is also the case that over the course of this treatment, we are targeting other things that could be mechanisms. I do believe that this treatment does enhance mentalization, and I also do believe that it promotes acceptance of internal experiences. So both of these are other candidate mechanisms. And finally, I did want to acknowledge my collaborators on this study. For anyone in this audience who has done treatment outcome research, you know it takes a village. And so I would like to acknowledge both my co-investigator as well as my consultants, 3 of whom are in the audience, and then also NIMH for funding this study. So, thank you. It seems like we might have time for questions. For the outcome measure, we looked at acts of self-harm. Over the course of the treatment, we did also monitor ideation and urges each week. What I can tell you is that overall, everything went down. However, there was a very large period of time when urges stayed the same and the behavior was going down. Yes. Yeah. Yes, I don't know if other folks heard it, but the mediation analyses actually showed changes in emotion dysregulation occurred prior to changes in self-harm.
It looked like the borderline symptoms stayed the same in the study going out 9 months.
Yes, during the follow-up period, yes.
Of the things that changed and didn't change within the subscales of that measure, were there certain cut out, or do you know that?
That's a really good question, and one that I'm now wishing I would have thought of before I got up here. The only thing I can say is that since it was of most interest to me, I looked at the emotion subscales, and that found the same pattern that we saw with the overall. I feel like there was one subscale that looked slightly different than the others, and now I'm not sure which it is, but my guess is it's cognitive, to be honest. Valerie? I mean, 14 weeks of DBT or DBT as a year-long treatment? Yes, I mean, so I think, the way I've always thought about this is DBT is a very comprehensive treatment, and it's meant to help with a number of different symptoms that these folks struggle with and really be very comprehensive, whereas this treatment is focusing solely on emotion regulation and self-harm. And so I think it allows us to really come in and target that efficiently, whereas we are probably not targeting other aspects of functioning that DBT does. Yes, that was, well, and one thing to note, and this kind of got cut as I was going through the slides because it was a briefer talk than I was expecting, is that part of the treatment, the last 4 weeks, is actually the part that is taken from acceptance and commitment treatment, which basically has people identify where they want to go forward in their lives, the things that matter to them, and then how to start moving in that direction. And so we really end clients with this idea of moving forward in ways that matter to them and how to overcome barriers. So I do think that that's one way in which quality of life really comes into play, that they are actively doing that, and they're doing it right at the end of treatment. So I think it's also why we're seeing these improvements during the follow-up period. Any other questions? All right, thank you.